When severe memory dysfunction strikes, a patient's internal map of reality breaks down. But that breakdown is not uniform. In some cases, the neural network simply goes dark. In others, it actively twists and misdirects the data. A patient presenting with severe disorientation presents a specific diagnostic challenge. The outward symptom, confusion, masks varied underlying mechanical failures. Clinical memory dysfunction presents in two distinct ways: the absolute loss of data, known as amnesia, or the active distortion and fabrication of data, known as paramnesia. This clinical matrix organizes the master framework for identifying the dysfunction. We start by defining the meaning of each disorder side by side. Amnesia is defined by a distinct loss of memory, while paramnesia is characterized by a distortion of memory. This directly dictates their actual recall capability. The amnesic patient cannot remember. The paramnesic patient remembers incorrectly. Accurately distinguishing between data loss and data distortion is a critical diagnostic step. Misidentifying the root mechanics of a patient's memory failure often results in applying the wrong nursing interventions, which actively worsens patient distress and agitation. Amnesia is the partial or complete loss of memory. It compromises a patient's ability to pull up past information or their ability to encode new memories. This timeline maps exactly how amnesia manifests relative to a specific brain injury or illness. Retrograde amnesia is the deletion of past events. Information encoded before the trauma is lost entirely. Clinically, this presents as a patient who retains their current operating capacity but cannot recall their childhood or major life events prior to their injury. Anterograde amnesia is the precise opposite. The patient's past memories survive intact, but the brain fails to encode anything new following the trauma. This specific failure to log new information is highly common in cases of traumatic brain injury and severe alcohol abuse. Other presentations are brief. Transient global amnesia involves a sudden, temporary memory loss lasting only a few hours. The patient typically loops, asking the same questions repeatedly until the episode resolves. Dissociative or psychogenic amnesia requires a critical distinction. It is triggered by psychological trauma, such as forgetting one's identity after a severe shock, and presents with zero organic brain damage. The remaining subtypes include infantile amnesia, which is the standard inability to recall early childhood, and post-traumatic amnesia, a condition extending memory loss to events both before and after a head injury. The causal categories for these deficits are broad. They range from physical traumas like strokes and encephalitis to chemical abuse, neurodegenerative diseases like Alzheimer's, and extreme psychological stress. Regardless of the exact subtype or origin, amnesia leaves a definitive void in the internal database. It strips away the patient's context for reality. Observationally, an amnesic patient displays profound forgetfulness, confusion, and a total inability to learn new information. They frequently lose their orientation to time, place, and person. Because the patient lacks internal memory data, the medical team is responsible for providing an external framework. This infographic details the concept of external scaffolding. The foundational step is securing a safe environment, protecting a patient who can no longer remember physical hazards. Next is continuous reorientation. Clinicians must deploy highly visible tools, such as large analog clocks and clear calendars, to tether the patient to the present moment. The team must also maintain a strict daily routine and place physical memory aids, including written notes and explicit labels on everyday objects, throughout the living space. These practical steps are purely mechanical. They require consistent emotional support to help the patient manage the anxiety caused by constant disorientation. Effective amnesia care relies on this predictable external scaffold. It systematically compensates for the patient's internal voids. The second pathology is paramnesia. In this state, memory is not missing, but falsified or heavily distorted. This diagram illustrates confabulation. When there are gaps in a patient's memory, the brain unconsciously fills them by generating highly detailed imaginary stories that link seamlessly to real data. The patient firmly believes these confabulations are factual. This behavior is a frequent feature of advanced alcoholism and dementia. Paramnesia also includes familiarity inversions. In déjà vu, a brand new situation is vividly and incorrectly tagged as an event that has already happened. The exact opposite is jamais vu. This occurs when a highly familiar, everyday situation feels alien and unknown to the patient. False recognition is a specific distortion where a patient looks at total strangers and confidently recognizes them as known friends or family members. Over time, patients may also exhibit retrospective falsification, unconsciously altering the details of past memories until the original event is entirely obscured. The primary organic drivers of paramnesia include structural brain disorders, various forms of dementia, severe psychiatric illnesses, and long-term substance abuse. Unlike amnesia, paramnesia is a failure of reality testing. The patient's internal world is vividly rich, highly convincing, and factually incorrect. Clinically, paramnesia presents as active false memories, severe misinterpretation of current events, and a profound inability to separate reality from imagination. This is exactly why the amnesia protocol fails here. External scaffolding, like sticky notes and labels, cannot override a brain that is actively generating its own false reality. The absolute constraint of paramnesia nursing management is non-combative. Do not argue with the patient about their false reality. Direct contradiction accelerates distress. Instead, clinicians must gently correct mistakes to maintain baseline orientation, providing continuous reassurance to de-escalate their confusion. Medical staff must closely monitor behavioral changes, as living in a distorted reality frequently causes rapid spikes in patient agitation. Managing a paramnesic patient requires precise navigation of their subjective reality, rather than a forceful collision with objective facts. Returning to our complete matrix synthesizes these two paradigms. The example row cements the behavioral contrast. Amnesia routinely manifests as a simple forgetting of events. Paramnesia manifests through the active generation of false memories. The cause row isolates their pathological roots. Amnesia is heavily tied to physical brain damage and trauma, while paramnesia typically stems from underlying psychiatric or specific neurologic conditions. Amnesia is the pathology of a wiped hard drive, requiring clinicians to provide external data drives through scaffolding. Paramnesia is the pathology of corrupted data, requiring careful navigation and system diagnostics. Accurately differentiating between the two ensures the patient is placed in the correct therapeutic environment, preventing clinical friction. Mastering this matrix transforms a highly confusing, disoriented patient encounter into a clear, actionable management pathway.